We're live.
Hello. We're live. We're live. I keep changing my backdrop. You don't. You're beautiful in your very. I'm now in my van again.
I'm here all the time. I never move, never eat, never go to the toilet.
Wait a minute. Let me try this again. It's canine arthritis management. Come on. Heads up. Yes. It's okay. We're now on 3 platforms, so it's okay.
3 platforms. Wow, that's fancy.
Yeah, no, it's coming out on YouTube, Holly's Army, and the Cam main page, but it had a little bit of a mood with me and said it wasn't going out on main page, but we are now, so this is all good. Cool. So Cam followers, please meet the lovely Dr. Kathy Murphy. I'm extremely pleased to have her back. I'm in my van, so ignore the backdrop. I've been locating in Cornwall and I just finished work. Kathy is in Newcastle and we're here to talk to you about pain and neuroscience. We are doing a little bit of a teaser because we've got an event coming up. On the 5th December, we are doing a deep dive into pain behaviour assessment, Moose's story. And that is available for you guys to sign up. So please do click on the link that you'll find in the thread for today, and I'll put more details afterwards. So me, Kathy and Bobby will be doing an event 5th December. Please come and join us. But until then, we
probably worth flagging up the early bird discount. I think runs till, is it the 21st or something, or 20th of November? So not long, only a few days left of early bird discount. Perfect. And yeah, we'll be covering a lot of the stuff that we talked about last time and this time, but in a much more educational format. So for those people that want to learn how to reflect on how that impacts their own animals or their clients' animals, or
and a lot more structured.
Yeah,
rather than
one of us just chatting.
So last week I was in a hotel room in London Vet Show. And now I'm in Asda car park in Cornwall.
Well, you really know how to get around.
I know. I'm so whoop whoop, Hannah. So today we're going to step away. We last week we're talking about the neuroscience of pain, and now we want to talk about the cognitive influence and the cognitive impact. And then next week we're going to talk about the emotional influence and the emotional impact. Now this is an area that Kathy really, really excels in. So I'm going to probably go a bit mute for a while, just going, what?
So that doesn't sound like you.
No, I am gobby. I'm just not as smart as you. That's the problem. I can't compete whatsoever. So we had a little bit of a plan. Tell us what we're going to talk about this evening. You've already got a scheme in your head.
Yeah, so I think one of the things that comes out in conversation, either with owners or with trainers or behaviourists, is why it is that we've got this correlation or this tandem relationship between chronic pain and mood disorders and cognitive disorders, so behavioural abnormalities.
Clarify what we mean by cognitive, because a lot of people go, I don't know what she's talking about.
Yeah, so I mean, there are different ways of kind of defining cognition, but the easiest way to define it is to say that it encompasses learning, memory, and attention. So it's basically our ability to think. So when we're thinking about behavioural cases, the important thing to remember with behavioural cases, if you're a trainer or a behaviourist, is that you could have impacts on cognition, so that's learning, memory, or attention, before you would see gross signs of chronic pain or gross signs of depression or anxiety, even though those pathways are probably leading to the cognitive impairment that's causing, let's say, for instance, things that people don't usually associate with chronic pain or indeed depression or anxiety, but things like an inability to pay attention during training. So kind of like, bouncing around all over the place and not really concentrating during a training session. Traditionally, we would approach those cases through creating structure around the training and changing perhaps reward value during training and cues during training, etc. So very training focused. Whereas actually, I think now that we understand more about the neurobiology of pain, mood, and how it interacts with cognition, we're recognizing that actually some of those cases, the underlying factor could be pain, or indeed mood disturbance, or indeed a mixture of the two. And that's being expressed as a change in cognition that we're seeing as bad behavior during training. So that's the kind of neurobiological link that I wanted to talk about today, because in terms of neuroscience, we've known about that for a lot longer than we've been talking about it. A lot of the neuroscience around, why is it that that link exists within the brain, we've known about for decades. It's just that nobody's ever really related that to the types of clinical cases that we would talk about on this sort of platform. So either in terms of behavior cases or pain cases, or mood disturbance cases, or what we actually really truly see is usually a mixture of all of those three. It's just that they're presented for one of those. So the owner may present at the vet's for pain, but actually when you question them further, there are some mood changes there, or there are some changes in behavior that would be associated with cognitive changes. So I think very much the field is kind of waking up to the fact that those cases are much more complex than we've given them credit for in the past.
I think it's so complex. This is the thing. What is so laughable, and this is the honest truth. I started CAM with such a naive understanding, and hanging out with people like you, you're like, oh my God, this is getting more and more complicated. How can we ever bring this to like first opinion practice? I've been working as a first opinion vet today, 10 to 15 minute consults, really busy. 1 minute you're doing a puppy pass, next minute you're doing anal gland expression. Then you've got a cranky old dog. Is it dementia? Is it pain? Is it something else? You're like, whoa, going into the detail that we get to talk about, bringing that back into practicality. God, it's tough, isn't it?
It's really challenging. And I think, at the moment, really the most useful kind of wake up, if you like, is that when presented with a case that is pain, you have to also consider, even if you don't consider at that point in time, because pain is the priority, you have to consider in the general well-being assessment of that animal, okay, at some point we're going to have to revisit mood, and at some point we're going to have to revisit cognition, because there may be things going on there that tie in with the pain and that may decrease when we give pain relief. So they may provide us with a way of monitoring how good the pain relief is at being able to control those pathways long term, but also could actually be impacting on well-being. In the early stages of pain could well be impacting well-being more than the pain itself, which is very common in the early stages. And that, I think, through discussion with various stakeholders, so physiotherapists, owners, veterinary paraprofessionals, professionals, etc., I think really we've not appreciated that enough, that in those early stages of pain where we say, oh, we can't really find any reason and we can't really find any obvious signs of pain, that those cases are pretty classic for early signs of pain, and they're actually displaying in terms of cognitive impairment or mood disturbance before they'll show obvious signs of pain.
And that, then, let's take it back to a practicality level. People are really like, well, what do you do? Because if you can't find a focus of pain, how do you move forward with that? And I was talking to someone the other day saying, well, if you think that there's pain, but you can't actually localize pain, then there's no harm in doing a pain relief trial. And then people talk to you about, well, how long would you do one for? And I find myself saying it could be 4 to 12 weeks. And having that kind of conversation with an owner that's got a fear of meds, it's tough, isn't it? I can't find the pain, but I think there's pain, and the only thing we can do is try and prove that there is by giving pain relief. And they're like, whoa.
Very much. Although I think there are some cases where the presentation is so serious that actually owners do want to rule out things. So let's take an aggression case, for instance. If you've got an aggression case and actually, they're managing things well enough in terms of safety, but they're obviously concerned about the pet because this, the aggression wasn't there before, it is now, why is it there, etc. You can't find a focus of pain, but in those cases I think it is really important to rule out pain, because not only can pain cause cognitive impairment, but it can have a direct impact on aggression. So in those cases, you can imagine that if they're working with a behaviourist and they've got a plan for dealing with the behaviour and kind of breaking down what's going on with the behaviour, in parallel to that, because that is going to take 6 to 12 weeks anyway on a behaviour mod plan, in parallel to that, if you include a pain trial, that's actually not extending the time taken to really understand what's going on with that case, but it is giving you huge amounts of important information.
New perspective.
Yeah, a new perspective in terms of being able to rule in or rule out certain things. But yeah, you're right. It's not straightforward, and in some ways I think that can kind of make us go, oh god, well, why should I bother, it's so complicated. But I think there's a great power in understanding that triad between cognition or learning, memory and attention, and I mean, we're going to come on to emotion next week, but and in terms of reactivity, we would call it kind of classically in dogs, but tendency to aggressive responses, for instance, that triad between the cluster of those problems with chronic pain, with mood changes such as depression and anxiety, things like separation anxiety, we haven't classically kind of thought of pain as being a factor in separation anxiety, and yet the more research that's coming out now, the more we realize that that may actually be a really important factor for separation anxiety.
Which is common. I know, when you kind of go, we haven't really thought about it. Now that I do, oh my god, isn't that obvious?
Yeah, kind of makes sense, because when do you become the most anxious about your pain? It's not when you're sitting in a pub chatting with your mates.
When you're lonely.
It's when you're at home and you're lonely and you're on your own, you've got nothing else to think about except for your pain. That's when the anxiety and or depression becomes more intense. So it's logical that we would see that with separation anxiety, and that those signals would be dampened when the pet feels the comfort of being with you, and that's a neurological, that's not I have thought myself out of pain, that's actually descending inhibition that occurs within the nervous system because we feel safety and comfort, so it decreases our anxiety and increases
I can do a little story about this. I had an absolutely adorable friend who sadly passed with a chronic pain condition, and when she was at work she managed it very well because her brain was busy doing other things. It was a lot, and she had her friends around her and she was having a laugh, which made her laugh, but at times on her own, horrendous.
Yeah. So I think most people can relate to that, either directly from experience or experience with a relative or loved one or friend, where that is the case. So yeah, it's like with a lot of these things, it's not that surprising once you think about it, but we just haven't really thought about it. And I think that's the thing about the link between pain and behavior, is that very often we've approached them separately. They have very separate disciplines. So you either go to see a pain specialist or you go to see a behaviourist, and the two are only just really starting to cross over and collaborate together. I think we've still got a long way to go, but they've traditionally been very separate routes of workup, separate routes. I should probably explain workup, shouldn't I? Because I got told off for that when I was talking to someone the other day. But by case workup, I mean kind of thinking about what's wrong, or what's actually going on, and diagnostic tests that might inform that process. So we've tended to either think, oh, it's behavioural, so we'll work with a behaviourist, or oh, it's pain, so we'll think about pain trials, etc. Whereas actually now what we're realising is that we shouldn't be separating those two, and there's a lot more crossover. And as we talked about, the Mills paper last week, that multi-centre paper suggested that up to 80% of a behaviourist caseload has pain as a factor. So that's incredibly important, and indicates that pain is massively underdiagnosed, and also indicates that pain is implicated in cognitive changes, cognitive and emotional changes that are leading to those behaviours, but is not easy to pick up in terms of pain is the underlying cause. Otherwise, obviously, they would have that picked up before they're referred to a behaviourist.
Okay.
So
we look at cognition from both angles, and so pain affecting cognition and cognition affecting pain, just to keep it really, really stupidly simple for Penguin Book me. So just to put this into kind of context, I can remember, one of our dear friends, Gwen, saying, my pain with all the conditions that I have is really affecting my ability to process and think fast and think, to the capability I had before. And I was like, that's obvious. Yeah, but I never thought of it like that. So how will that present in a dog? Possibly a little bit vacancy, possibly not so quick to respond, possibly distant.
And also possibly frustration. So a lot of these dogs that present as scatty or jumpy up, or not able to concentrate, all over the place, this kind of behavior, sometimes that is simply because they can't concentrate on the task. And they're, we know from neurobiology that there is a mechanism that could explain that from chronic pain, because chronic pain impacts on their ability to pay attention and also to process information. And so what do? They do the same thing that humans do, which is distract themselves. And they can't communicate to us. So a human will come to us and say, like like Gwen did with you, this is what's going on for me. But of course the animal can't communicate that, and we're still expecting the animal to perform whatever task we're expecting them to perform. So to sit when visitors come in, or is an example I use, but it could be any example, or to follow the same behavior patterns and response to cues that they've been following before. And they can't tell us, hang on a minute, I can't concentrate on that. So they may well present as frustrated or overexcited, or what I would call kind of attention deficit type presentations.
Yeah. Okay.
And then coming back to the neurobiology, what's really interesting is that there are a whole range of common pathways between pain and cognition, and pain and mood. So if you look at brain-derived neurotropic factor, which is a chemical, if you like, in our nervous system. So this is essential for healthy, normal function of neurons, and also essential for healthy, normal function of non-neuronal cells. So all of those cells, like glial cells, astrocytes, that surround the neurons, that provide it with food, provide it with oxygen, provide it with nutrients, provide it with the right environment to be able to function normally. And brain-derived neurotropic factor has been implicated in the modulation between chronic pain and depression, and also between chronic pain and anxiety, and also between anxiety and depression, all in separate studies. So you can see here, you've got, this is just one neurokine, or just one factor here within the environment of our nervous system. But abnormalities in that one factor, so genetic abnormalities in that one factor, or genetic changes in that one factor, can affect all of those pathways. So the modulatory pathways between each of those factors. Well, if that's happening, and it has been shown to happen in those three pathways in parallel, of course you're going to have interactions between the expression of chronic pain, cognitive impairment, and mood disorders. You can't not, because they're entirely common pathways that share common chemicals. So when you get disruptions in those chemicals, you get disruptions in those pathways. And actually what's really interesting about some of those pathways, so they looked at the impact of genetic changes to some of the serotonin receptors. So serotonin is one of these chemicals in the brain that we classically think of as kind of the happy chemical, if you like. So it's very key for mood and also for memory, so also for cognition. It also plays a role in pain processing. So again, you can see these common factors. And actually genetic abnormalities in a subtype of receptor for serotonin, there's like lots of different serotonin receptors, but particular subtypes, has been associated with a disruption in the synchronization or harmony between those different pathways. So pain processing, and if pain processing pathways are disrupted, that means that you get pain occurring where it shouldn't be occurring. So part of the chronic pain is that the pain itself becomes a disease. So the serotonin is really key in that disruption. So if you get changes in serotonin receptors, you get disruption in that pathway. So you're more likely to get chronic pain as a disease entity in itself. But you also see mood disturbances and cognitive disturbances. And what's interesting about that research is that that's only seen in female subjects. I know, right? And yet most of our preclinical research, arguably almost all of our preclinical research in those areas is conducted in male subjects.
Wow.
So we haven't even tapped into the impact of that pathway. And going back to a conversation, did we have a conversation about the development of analgesic drugs last week? I can't remember whether that was.
No, we didn't. I don't think we did.
Oh, okay. So maybe I should just shut up and not go there.
Leave that one, because we've already hit 20 minutes. And I want to just reverse something, because I want people to not go away frustrated.
Yes, yeah. So we need to bring it back to what we can do.
So we need to flip that thing again, because one of the reasons that I want people to listen to about neuroscience and pain is, yes, we need to use it to detect pain, but we can also use it to influence pain. So can we flip and talk about cognitive influence on pain?
Yeah.
So that is these distraction games. This is going out, getting engaged, not engaged like married, but being engaged in activities. I want your dog to go get married. That's not normal. But go and, yes, shut up, Hannah. But can you flip it for me so people can go away with going, oh, right.
Yeah, so absolutely. You're quite right to point out that because we've got those common pathways, when things go wrong in those pathways, we can end up with disturbances in those dimensions. But what it does mean is that we can tap into those pathways in order to support an animal that's struggling in one particular area. So if you have an animal in chronic pain, because of those common pathways, if we're influencing mood and if we're influencing cognition, so you gave some examples, if we're providing enrichment for our animals that can have an impact on both cognition and mood, because it's helping the animal's brain to think, and it's also bringing about a kind of emotional balance, if you like, or a sense of calm. If we do scent work with the dog, which can both enrich in terms of cognitive function and give the brain something to do, and actually the cognitive processing involved in scent work, I think we've talked about this before, is particularly useful because it's a primary sense for the dog. So it's something that the dog finds enriching in its own right. Doing scent work doesn't have to be rewarded by us, because it is actually rewarding for the dog anyway to do scent work. So if we're providing those enriching activities or enrichment via food enrichment or different enrichment activities, we are influencing those common pathways, and that will have a knock-on effect on pain. And we've shown that in human patients who can report their pain. It's difficult to show that at a behavioural level in animal models without very invasive neuroscience, so shoving electrodes in animals' brains, which obviously is not ethical unless, blah, 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 blah. That's a separate talk. But there are limitations to us doing that in animal species. But of course, in humans, we don't need to do that because they can tell us. And that's been shown by large group patient studies across.
So can I just now take this into first opinion practice again and just see what people's response will be to this? Okay, so I'm in a clinic, I'm in a room. I'm dealing with an osteoarthritic dog. They've come here for a 10 to 15 minute consult. We've done an assessment. We've decided that the meds need changing a little bit. We've got, we're not doing them according to their time scale. So we meddle a little bit, maybe change the dose. And then I whop in with this. I'd like you to go in the garden and collect things from the garden and put them on a tray and put them in front of his bed on a daily basis. I'd like you to save every single carton that you ever use, smear it with pate and hide it around your house. Do you think they're going to take me seriously? No. So this is one of the reasons that we use CAM, because that is an impossible conversation for a first opinion vet to have without that owner just going, they're barking mad. So I think it's so true though, isn't it?
Yeah, it is true, and it's impossible unless you come at it from the scientific angle. And this may require, I mean, I'm just thinking now that maybe we should actually produce some like owner help crib sheets or something. But if
like
you actually
interpretation, vet interpretation, you know, so
yeah,
that
if you actually come from, we've learnt this from human patient studies, and now human patient chronic pain care has moved towards these interventions, towards non-pharmaceutical interventions. And actually there have been large scale patient studies that have shown that they've had a large effect size, so a large impact on quality of life. So we already know that that is the case. We also know from animal studies, so it's not just human studies. So the idea that this is just a human effect and not an animal effect is not the case. We're building more animal studies in this area, but there's a whole bank over the last 20 years or so that show that non-pharmaceutical interventions, such as enrichment, impact on pain scores in animals. So we know that that is the case. So I think if you start the conversation from there and get the owners used to the idea that managing chronic pain, we know that we can't manage chronic pain with pharmaceuticals. We may be able to in the future, but we're really bad at doing that now. It just doesn't happen. And in the early stages, yes, it might be more successful, but it's never 100% successful. Like it just, we don't have the drugs available to us. But because we know that we can impact quality of life and pain scores, i.e. and the experience of pain using these non-pharmaceutical interventions, then it is worth thinking about how we might be able to incorporate this into our dog's life. And my suggestion would be that we almost leave the conversation there in the first consultation with the client, because they've got enough to absorb, right? It's a lot. It's stressful enough going to vets.
It's not going to be a conversation. One of the things that Cam found at the beginning is that people switch off. So we went for strong branding, consistent branding, dabbling with a slight scientific language to put a little bit of a push in the this is scientifically evidenced, and booklets and handouts, because I've experimented so much in first opinion consults trying to get these points across, and it just doesn't resonate in that room.
Yeah, and from a neuroscience perspective, that's obvious, right? Because as a client, you've got a million things going through your brain that are not just the information that your vet is telling you. You've got the anxiety about, is my pet okay? You're also keeping an eye on what your pet's doing in the consult room. And you may also be keeping an eye on what your kids are doing in the consult room, or, you know, your parking ticket time or whatever else, like, you know, having to get home to cook dinner. Like it's not a relaxing environment where you can absorb information.
No.
And I went for we were talking earlier, I went for a hospital appointment today. And I had that exact experience. But within 5 minutes, I said, gosh, it's really strange, but I actually feel really emotional during this consult. And she said, yeah, that's not unusual. And I was like, yeah, but I feel like a failure. I feel like I should be able to emotionally cope with this. I am actually a medical professional, but because it's you, it's completely different. So I think, yeah, I don't think we can deal with pharmaceutical and non-pharmaceutical intervention right at the beginning all at once. I think that is a step too far. And also I think there's a benefit in terms of case workup, going back to how we manage cases. There's a benefit to breaking some of those things down so that we can actually see what the impact of individual changes are. So, you know, if we're starting painkillers, we can see what the impact of those are before.
Which leads on to a really good question, which I've got up here. Would it be worth taking a lifestyle diet choice with an anti-inflammatory, anti-stress approach before hitting the meds?
So, yeah, that's very case dependent. So that really does depend on what's going on for that individual animal. So you couldn't say yes or no to that, because it will be different depending on what's going on.
Can I also butt in on this one? We have to bring in. I'm going to butt in. Let me speak.
Yeah, why don't you butt in? Yeah. It's not good for you to be silent for too long.
No, I'm getting here. We also have to look at it from the aspect of that vet trying to get that owner on board. And those changes are going to take a long time to have effect generally.
Yeah.
And when I'm working with a client, for them to believe, trust, have faith, continue using my services, I've got to get something happening pretty damn quickly for them to buy in and continue. So it's not that what Lynn's saying is wrong. It's just it's back to the same supplement debate. I wouldn't have a dog in pain. It's not a welfare approach and go, we'll try a supplement first. I'm definitely going to be, for welfare reasons, putting the dog on pain relief, and also to get that owner buy-in so that they can see improvements, so they stay with me on that journey.
Yeah, and I think by the time the animal's presented at the vets, the pain's already quite bad, right? It's certainly obvious, because otherwise they wouldn't be presenting at the vets, and it's probably not transient or, you know, short-lived. It's probably been going on for a while, or been on and off going on for a while. So you're already into the kind of second stage. I think what I was going to say is that those lifestyle changes are really key early in life. Before we see signs of pain, we should already be thinking about, you know, making sure that we've got those patterns set up so that we're supporting that whole, those neurobiological pathways as much as possible. We don't have enough research to know about how much early intervention in terms of non-pharmaceutical interventions can offset the development of chronic pain or the obvious signs of chronic pain later in life. But that's where the field is going now, looking at, okay, what happens if we start with the non-pharmaceutical interventions at a much earlier stage? So that's where the owners, I think, you know, thinking about what can people take away that gives them some power or gives them, you know, something that they can implement. That's where I think owners really can take something away from this, is they don't have to feel like, I think from talking to people, for owners and also sometimes vets, I think it's like this idea that we just have to watch this deteriorate until it's so bad that we put the animal on pain relief. Well, actually we don't. There's a lot that we can do in that period where we're not quite sure, you know, is it pain, isn't it? It's just, she's a bit stiff sometimes, but most of the time she runs around fine. There may be a lot that we can do in those early stages to support that animal that may delay the onset of obvious signs of pain, and may delay the onset for the need for analgesia. And it, you know, I'm sure you've had lots of discussions about, you know, the potential side effects of analgesia. We always want to make sure that we're using analgesia when the animal's in obvious pain, but if we can delay the need for that, then we're delaying the need for those pharmaceutical interventions that may have side effects.
Yeah, but that again, it takes owner buy-in. And what I was just daydreaming about, sorry, it wasn't that I wasn't listening, but
it was that you weren't listening. It's fine.
Okay, it wasn't. Yes, I switched off. But isn't it interesting the detail that we will go into for our own dogs, but we are terrible at applying it for our own physical health? You know, I'm in my 40s and I don't do half the things I should do for my mental and physical health, but I would do anything for Luna. Yeah, it's crazy, isn't it?
Yeah, I think that, I mean, a lot of us are like that, aren't we? Maybe my dogs would be happier with you. I think you probably do more for them than I do.
And Dennis, come and live with me.
Dennis is having a revival, but that's
Dennis. He's just out there, isn't he?
Yeah, and actually that's interesting, because that's, you know, in terms of controlling chronic pain and controlling mood, you know, I can use environmental enrichment to improve his mood, and that gets him moving around, and he seems like he's in less pain. He's certainly less lame if you score him on lameness. But interestingly, when I switched his analgesic regime, he then had more interest in enrichment. So you can't say it's one or the other. Both are really parallel and really interconnected. So any gains you can make in either of those is going to help the other. But I would say if your pain relief regime is successful and you think it's impacting, that's really the time to introduce the enrichment, because that's when you're going to have the biggest gains, and that's when your animal's going to be the most motivated to get the most out of those enrichments.
Yeah. Well, this like the final point is, do you remember when I was staying at your house and I was having to do a lecture about chronic pain questionnaires? So the validated chronic pain questionnaires. Park, and I just went, I don't get it. There is no way that a chronic pain indicator questionnaire is any different to a quality of life. They overlap entirely. And you went, yeah, obviously, Hannah. I was like, sorry it took me so long to get that.
But that's because classically we've separated the two, right?
We've always classically
completely different disciplines, and yet they're so not. And it's really interesting that actually when you go to the neuroscience literature, it's not like we're discovering this in neuroscience now. We discovered it ages ago. It's just that we didn't actually apply it to this environment, to the clinical environment.
Yeah, no, definitely. Let's just brainstorm this last one, and then, because Lynn's always great at bringing stuff to the table, and this is a common problem. So a big percentage of CAM followers are canine professionals, paraprofessionals, etc., and they work tirelessly to bring the best for their clients and their dogs, and they work with the vet. But that is a common thing, saying, I've noticed this, I've spotted this, this is what I'm going back to the vet. Can you give them any advice? What sort of thing would you say to these people?
So I'm going to ignore your question like a politician and say that, having thought about this issue a lot, I do think that there's something that we need to do in veterinary education. And what I've noticed is missing in the universities is that when people do their anaesthesia rotations on clinics, we don't talk to them about pain. And we definitely don't talk to them about non-pharmaceutical interventions for pain and the link between chronic pain, mood, and cognition. Like, that just doesn't exist currently in the syllabuses.
I was going to say, yeah. Sounds like a hurt.
So I do think that you're pushing treacle uphill because it's not a subject that's taught, and so it's not something that clinicians are familiar with unless they have a special interest in it. You really have to have a clinician that has so much of an interest in it that they delve into the literature, and therefore they're coming from that kind of angle. So I'm not saying there's nothing you can do, but I think there's a limit to what you can do until we address that. And it will happen. It's certainly happening if I get my diploma, because And I think there's a much greater understanding that physiotherapy is not complementary to veterinary medicine. It's absolutely bloody essential to veterinary medicine, and it's a discipline in its own right. We're complementing them half the time rather than them complementing us.
Oh, yeah.
So yeah, I think it will change, but I really think we need to address that. I don't think we teach pain and pain management very well in vet schools. That's my opinion and my experience. But in terms of what you can do, I don't know. I'm gonna go over to you, Hannah. I think it's really about looking at what we can do to assess pain and quality of life and well-being with metrics that the vet can kind of, get a handle on. This is what I was
going to say. I think let's now go into that vet's experience. So that vet's had an owner come in. That owner might have been very hesitant about interventions. The dog might be quite young, so trying to look at the tools that vet has in their arsenal to have an impact that could have an adverse reaction. The owner's not quite sure it's a problem either. As a vet, saying, I think there might be some discomfort here. The owner's adverse to the pain relief. Is it going to be putting this dog on pain relief long term? What happens if the owner's not on board? They're paying for this drug and then we get diarrhea. Oh my God, I'm going to be hated.
Or sued. That's usually what most vets think.
Yeah. So from the other side of that table, that vet may have had to make a judgment call where they didn't feel that it was impacting that dog's life and quality of life to the degree that would warrant those risks. So I would say that we need to start creating a kit to provide a therapist or a paraprofessional all forms of media delivery, data collection, that they can present a case that's more objective than this therapist thought this, what do you think, vets, in a completely different contextual environment. But if there was video material, if there was postural change, if there was measurements, if there was data collection over time, so it was a consistent finding, it was a progressive, that vet's going to go, oh crikey, that's quite a lot there. I'm with you now. But I know in the past when you have a random comment, I mentioned, I think last week, how guilty I feel when I used to have consult with people going, oh, he doesn't use his tail anymore, should I be worried? I'd be like, didn't get taught that. Does that warrant me putting you on an anti-inflammatory?
Yeah. Is he okay in every other way? Is he bright, alert, and responsive? Yes. Okay. Well, maybe. I don't know.
Yeah, it's tough, isn't it? I think what we should do is actually try and work out how that bridge is going to look and how that data is going to slide from one path to the next, so that we can work better together.
Yeah, and as an example, Bobby and I were discussing a case this week where there was that disconnect between the first opinion vet who wasn't recognising any signs of pain. The dog had been referred for behaviour problems, and actually it wasn't obviously in pain then either, but Bobby had shown me some video footage and I said, hang on a minute, there's something wrong with that dog's locomotion. I think you need to take it back and get it worked up for lumbosacral area or whatever. It's kind of irrelevant. And we were talking about, well, how do we bridge that gap? And I said, I honestly think you're not gonna be able to detect signs of pain on a physical exam, as is proved by the fact that the first opinion vet couldn't find any signs of pain. You're not going to be able to detect signs of pain by trotting it up in the surgery, because it's not that bad that you'll be able to see anything. But show them video footage of what we're seeing here in its home environment when it's relaxed, when, you know, it's not stressed at the vets and therefore ignoring its pain, etc. And I think if you point out, look, we're seeing asymmetry here and we're seeing curvature here, then actually the vet will be able to say, oh, okay, that's not visible in the vet surgery, but I can see what you're talking about on the video. Yeah, so now I think we need to look at pain as an underlying cause for the behaviour problem. I don't know what the outcome of that conversation was, but I think that's the approach we need to be taking, is understanding that it's actually really difficult to identify anything other than agony, or what I would call moderate pain, in a vet surgery. I don't think we ever detect mild pain in a vet surgery.
No, totally agree.
Yeah.
Totally agree.
And actually with my own dogs, I don't detect mild pain when I physically examine them, because they're stressed by the fact that I'm behaving weirdly, because I'm physically examining them. I can only detect or locate the pain when it becomes moderate. And that's with my own dogs, not taking them into an unfamiliar environment. So I genuinely think, I mean, I've said this before, but my opinion is that we're really bad at being able to detect mild to moderate pain, that we're only actually able to detect moderate to severe pain.
Yeah, no, totally agree. And on that note, we said we're going to talk for 20 minutes. You have been talking now for 40 minutes.
Amber Batson said last week, well done on talking for 20 minutes. I think we talked for about an hour last week.
No.
And it is Batson, it's not Bateson.
But it's Batson.
It is Batson, yeah.
Okay, we'll get it right. Okay, we'll get it right. So, guys, one of the reasons that we're doing this is because me and Kathy are going to keep you for at least 5 days, even though it's only registered for 8 hours, in a deep dive. So it's a really, really cool collaboration between Bobby, Kathy, and myself. It's on the 5th of December. We'd love to see you there. And it's just going to be going into this in a lot greater detail. We're trying to just skirt over it to give you like a little bit of an idea of how it's going to work. So that is on the 5th of December. Links are in the stream.
And I think
my laptop's going to die.
Oh no.
Yes.
Right, we'll talk about that next time.
Not allowed to anymore. Thank you guys so much for watching. I've got to go and find somewhere to stay tonight. You've got to go.
You're welcome to stay here. It's only a 7-hour drive. Oh, I think Hannah's definitely gone. Okay. Thank you very much for listening, everyone. Take care. See you next time.